great pleasure. Great pleasure today to welcome our colleagues from the Specialist Integrated Haematological Malignancy Diagnostic Services, which is not actually interchangeable with HODS, but we'll explain that as we go along. Our colleagues from there, Dr. Anna Godfrey, who's the lead for the SIHMDS, Livia Razzo-Barnett, who's a histopathologist, who many of our histopathology colleagues know, and Dave Bloxham, who's the operational lead for the service. And we've been discussing with Dave. Dave's going to come along at the later date and do a bit more around the science of flow cytometry for us. I'd like to welcome our colleagues from GLH who are here today as well, equally as important to them. And just like to say thank you to Anna, Livia and Dave. And I'm going to hand over to Anna, I believe, to start.
Yep, brilliant.
Right. So if everybody can mute, please, and any questions in the chat. Thank you.
Brilliant. Thank you, Colin, and thank you so much for the invitation to us to come and speak to you all today about Specialist Integrated Haematological Malignancy Diagnostic Services, what we are, why we're here, and how we do it. So today, Livia, our lead haematopathologist, and me, I'm the clinical lead and a consultant haematologist. We're going to go through some slides about what we do, and we also have David, who's our operational lead and principal scientist in the flow lab, to answer any questions. So this is the tree of hematopoiesis, for those of you who are not familiar with it. This is where all of our hematological neoplasms come from, and very broadly we divide things into myeloid and lymphoid malignancies. And I'm not going to go into this in any detail, but I just wanted to bring out a few key themes about hematological cancers. And these were things that were brought together by NICE in 2003 in a document called their Improving Outcomes Guidance for Hematological Cancers. And this really explains a little bit about why our services have been designed and put together as they have been as SIHMDS services. So first of all, within hematological and lymphoid cancers, there is a great deal of diversity. This is our current WHO book, which is the 2016 book, which has amongst its chapters 95 lymphoid neoplasms and amongst other things, 42 different types of acute leukemia, of which 23 of those are defined by specific cytogenetic and molecular abnormalities. So we have to have those tests done to get the correct diagnosis. Hot off the press, the 5th edition is on the way with a pre-publication in leukemia just a few weeks ago, and you can see that the number of entities has gone up even more. There are over 20 lymphoid entities that hadn't been previously included or have changed in some way, and we now have, for example, 29 acute leukemias that are defined by specific genetic abnormalities. So what does that mean? Well, as NICE pulled out, it does mean that some of the entities that we're looking for are really quite rare. And to summarize a lot of data, some of which is of variable quality, when people have done studies looking at where diagnoses are made, they found that there is a discord, that there can be differences in diagnoses, and that sometimes when those diagnoses are not made in a specialist centre, the incorrect diagnosis is made. So the discordance rates between an initial pathological diagnosis and review in a specialist centre varies in studies between 6 and 60%. And in one of those studies, for example, 46% of patients who had received a diagnosis of lymphoma and got a discordant diagnosis would have had a different therapy based on that new diagnosis. A second point about our cancers is that we very, very often, so in the majority of cases of bone marrow, for example, require a multimodality approach to get the right diagnosis. So when we receive a sample in the lab, this is a bone marrow aspirate at the top and a trephine biopsy just as an example below. We first look down the microscope, but then we decide what other tests that we need to do as they're relevant. So we might choose to do flow cytometry, FISH, we might do a karyotype or SNP array to look more widely at the chromosomes, we might look at single genes, we might look at multiple genes these days by an NGS panel. We might send a sample off for an RNA fusion panel, and in the vast majority of our solid tissue samples, we do some immunohistochemistry. But then we very importantly need to bring that all together into what's called our final integrated report. And that synthesizes everything to bring together the accurate diagnosis according to the WHO classification. And we also put in that any key prognostic information or really key information about potential therapies, particularly targeted therapies for the clinicians. And just as an example, we pulled out 3 weeks worth of aspirate data from May this year. And if you consider morphology to be one modality, flow cytometry to be another modality, FISH to be another modality, for example, this shows the numbers of modalities of testing that we did on each of those aspirates. So you can see the vast majority of aspirates have at least 2 modalities of testing, and many more have more than that, and that doesn't even include the Trefine. So the majority of samples are receiving multiple modalities of testing. Another consideration around our samples is that many of them require rapid processing. So many of them need to be processed for RNA, which requires 48 hours. And for some of our MRD testing, that actually needs to be done in a laboratory on the other side of the country. So we need to bring those samples in very quickly and get them out in a very speedy fashion. We also very often have quite limited tissue that requires multiple tests to be done on it to get the right diagnosis. So as with many of you, I'm sure we're being asked to do more and more on less and less with EBUS, for example. And here's a lovely example from Quiva. This is an occipital mass biopsy with a really tiny bit of tissue on which she was able to do immunohistochemistry and FISH to get the diagnosis of follicular lymphoma. And finally, we have essentially all of the samples that we're looking at that are new diagnoses, there is a suspicion of cancer. So there is clinical urgency for all of them. And in particular, we have some very highly aggressive malignancies, particularly the acute leukemias and high-grade lymphomas. And some of those require multiple modality testing to be initiated within hours of sample receipt. So here's an example. This is a bone marrow smear where we're seeing immature cells that have a very characteristic appearance. These purple lines in here are our rods, and this is called a faggot cell, and this appearance is very suspicious for a form of acute leukemia called acute promyelocytic leukemia. This is a hematological emergency, and we need to get a sample straight over to our colleagues in cytogenetics to test for this abnormality, which is PML-RARA, and you can see that this test is positive. Why is that so important? So this type of acute leukemia actually has a very good long-term outcome, but in the immediate term, they often present with disseminated intravascular coagulation, and they have a very high risk of death from bleeding, often within hours of presentation. So we need to get that information. The patient can start treatment immediately with a drug called Atra, and once they're onto that, they often have a very good outcome. So we need to get these samples straight onto their testing. So these specific points about hematological cancers were brought together by NICE in a document called the Improving Outcomes in Hematological Cancers in 2003. And to summarize a lot of their information, the conclusion that they came to was that in order to reduce errors, every diagnosis of possible hematological malignancy should be reviewed by specialists in the diagnosis of hematological malignancy. The results of those tests should then be integrated and interpreted by experts who work with the local MDTs and provide specialist service at a network level. And this is most easily achieved by locating all specialist hematopathology diagnostic services in a single laboratory. So as a result of that guidance, there was a tender process in East Anglia a little before 2015, and that was ultimately implemented around about 2015 in a gradual process across the region. So before that happened, things would have happened in a much more fragmented way. So this is just an example. This is not actually what used to happen in Ipswich, but I'm just giving you an example. But we might have had a hematologist in Ipswich reporting their own local aspirates, a histopathologist in Ipswich reporting the bone marrow Trefine. We might have had flow cytometry happen in Cambridge. We might have had molecular studies being performed in Cambridge and cytogenetics being performed in a different laboratory in London. And similar things to this did happen. Those different reports would then only have been integrated either at a local level by the treating clinician or at an MDT, or there wouldn't have been a single specialist pathology review who could look at everything, particularly if things didn't quite make sense together. There wouldn't have been a single IT system or any final integrated report. And we often found that we were using tests inefficiently. So for example, that cytogenetics lab has no idea what the local morphology actually looks like. So they may have a query of MDS because the patient's cytopenic and do some cytogenetics to look for that, when in fact, the flow cytometry suggests the patient has hairy cell leukemia. So we often were using tests quite inefficiently. Since 2015, we've gradually rolled out a programme of bringing all the samples in the region to HOD. So all samples with suspected hematological malignancy have now been sent to a HOD specimen reception. They're screened with the appropriate tests selected, and that's then collated into a final integrated report. And then a HODS consultant is present at each regional MDT. We serve about 7 MDTs in the region, and that was the case set up from around 2016 in the region. Of course, we need some staff to do that. So in the department, we have 4 consultant haematologists. Some of us also do a little bit of clinical work. We have 3 full-time consultant haematologists, in addition to Liz Swire, who's an academic, and John Grant also contributes to the service. And those 3 full-time consultant hematopathologists, which is Joy Staniforth, Quiva Egan, and Livia Rasho Barnett, those are people who have trained in histopathology, but they spend their time down here because they have chosen to be monospecialist hematopathologists, and it's much better for us to have them down here so we can integrate our results fully. Of course, we also need a full team of scientists, and they support our flow cytometry laboratory, the pre-screening of samples, and as well as our specimen reception team, together with quality and IT and administrative support. So here's just an example of how it can all fit together. I've chosen acute myeloid leukemia because I'm predominantly a myeloid doctor. So for a sample that comes in, we will look at the morphology really within an hour, often more quickly than that. We'll then do some flow cytometry, and that will confirm that it's acute myeloid leukemia. And I've said 4 hours, but to be honest, it's often a lot quicker than that, particularly for a new presentation. We'll then get some samples over for cytogenetics, and that's to look for both good risk and poor risk abnormalities, which determine the patient's first course of chemotherapy. So they need that information before the patient gets any chemotherapy in most cases. Some of those results will be within 6 hours if we think it might be acute promyelocytic leukemia, and the rest come back over the course of around 48 hours. Once the patient's got onto their first treatment, we still need some rapid turnaround time, single gene analysis for urgent mutations, and that's genes like FLT3, where we have targeted drugs against those mutations, and that still determines some of the targeted therapy that they have within their first course of treatment. And over that first week, the trophine biopsy also comes back, confirms the type of leukemia, and also excludes any other histological diagnoses. Over the course of the next 14 days and the coming weeks, we then look at the full karyotype together with a myeloid NGS panel, and that will confirm the final diagnostic subclassification, the risk group for the patient, and then their subsequent treatment after their first course of therapy. And that may include further chemotherapy or stem cell transplantation. And then critically, all of that information goes into a final integrated report, which puts it all together. I say that that goes into the integrated report, but all of those reports will come out to the clinicians as they're ready, and we don't wait for the final report to be ready. So here's a case as an example. This is from a few years ago, a lady who's still in my clinic. So she's a 71-year-old who presented with anemia and thrombocytopenia. And for those of you who aren't so familiar with peripheral blood, this is a normal neutrophil. But these cells here, which are immature cells, should not be there. So these are blasts. And we can guess that they're probably myeloid blasts, but we can't tell that purely on morphology. Her bone marrow aspirate was not a very good quality sample, but essentially we couldn't really see any normal hemopoiesis. We could just see these abnormal blast cells. So we need to then confirm what type of leukemia this is, and we then go on to do some flow cytometry. So I'll just summarize this for you. So we have the blast region here, which is in red. These cells express myeloid antigens, so they express CD117, CD33, and CD13. They also express some weak CD64, which tends to be towards the monocytic lineage, and they express they express myeloperoxidase. That's one of our critical myeloid antigens. They've also got some aberrant markers such as CD56, which helps us follow them up in the longer term. And we haven't got CD9. We haven't got CD9 on this plot. They don't have, importantly, other markers such as CD3, which would be a T cell marker, and some B cell markers. So thanks to Dave for the plot. I've whizzed through it, and as I say, it would be good for Dave at another point to go through flow cytometry with you. So that tells us that this is acute myeloid leukemia. We then go into some additional tests. So we have a FISH panel and a karyotype, which is normal. And then we go into do molecular studies, which in her are quite informative. So we do some single gene abnormalities, which are FLT3, which were negative, but an NPM1 mutation was detected. So you can see here the negative control, which is in green, a positive control in blue, and the red, which is the patient. So this gives us a diagnosis of AML with mutated NPM1. That is its own category within the WHO, and that allows her to go on to have specific treatment. In fact, in that case, that wasn't the full story, because on her trophine histology, we found some additional findings. So this is a trophine. You can see it's got some areas that are a little bit variable. This area here shows these immature looking myeloid cells, and indeed stain up with CD117. It's not a very strong stain, and these are the myeloid precursors consistent with her AML. But then we also have these areas which are paler, and you can see these cells look a little bit more spindled and the area looks more fibrotic. These stain densely with CD117. Mast cell tryptase is never our strongest stain, but they are also positive for mast cell tryptase and also for CD25. So these are neoplastic mast cells. She's positive for a KIT D816V mutation, and that makes the diagnosis of systemic mastocytosis. So in fact, her full diagnosis is systemic mastocytosis with an associated haematological neoplasm, and that haematological neoplasm is AML with mutated NPM1. So that is her full diagnosis, and we have needed every single modality of testing within our laboratory to get there. So here's her integrated report. I've taken out some patient identifiers, but you can see that we have the case, we have the type of samples that we've received, and then we have the morphology, the flow cytometry, a summary of her FISH and karyotype, her molecular genetics, which these days would also include NGS, but this is from a few years ago, her histopathology findings, and then a conclusion which gives the final diagnosis. And we would also include in that any very key prognostic and therapeutic information, which we now do increasingly as some of these molecular findings become more pertinent. So that's an example of what we do and how we do it. Just a few slides now about how things have changed a little bit more recently. So this is how things used to work. We had everything within HODS. The one exception, which is an abbreviation for this slide, is the parts that are performed with many thanks to our colleagues in immunohistochemistry on the solid side of our work. So the aspects that are done within the immunohistochemistry lab. All the aspects in blue used to be done within HODS, and we used to have this on level 3 under a single management structure with a single quality management system and co-located in a single laboratory. But of course, now we have the GLH and things are a little bit different. So the GLH has taken over the tests that are shown in the red boxes here. So cytogenetics and molecular genetics for liquid samples, and FISH and molecular genetics on solid samples. So now that that has occurred, the GLH has a separate QMS and management structure. It's in a different directorate, and those tests are performed in a geographically separate laboratory on level 6. And those tests are also commissioned differently, so the users no longer have to pay for them. And we have provided to provide a billing for the aspirate flow cytometry and solid tissue tests, whereas these tests in red are centrally commissioned by NHS England. So essentially, these parts in blue remain within HODS, whereas these parts in red are done by the GLH. But what's really critical for us is that we still continue to put everything together into our integrated report, and we do that function down in our SHMDS. And that remains really critical according to the NICE guidance to make sure that we get the final diagnosis right and the right information for clinicians. And actually, it's thanks to EPIC that we can do that really well, and we're very fortunate that that works so well for us. This is one of Livia's slides, and she's nicely put together the really important contribution in brown that the immunohistochemistry contribute, which is put a little bit better than on the previous slide. So towards ultrafine biopsies, together with the lymph node and extranodal tissue samples, both in terms of the pre-processing and the immunohistochemistry. And then just before I finish, the last thing I'm just going to mention is just to illustrate in a little bit more detail about how things have changed for our solid tissue specimens with molecular requesting. In the previously, this would be, for example, for clinality, we had a number of things would happen under one roof. So that would be the molecular request from the lymphoma pathologist, cutting of the molecular sections, the extraction of the DNA and quality check, primary analysis, final analysis, and sending out the report. And of course, when you're all in one laboratory, it is very easy to do that communication and troubleshooting. Whereas now we're in a situation where the molecular request comes from us on level 3. We then have the sections cut in the histodomain laboratory, the analysis, the primary analysis, as well as that first extraction check in the GLH, and then the final analysis in HODS. And obviously that's presented some challenges, but I think on my final slide, what I really want to do is to thank all the people here who have helped set up those pathways, to do some of the troubleshooting, and to help us improve some of those turnaround times in this new situation which we found ourselves. So I'm now going to hand over to Livia, who's going to give us some more cases and hopefully show you a little bit more of how what we do works so well.
So, yes. Can you see my screen?
Yes.
Just a quick disclaimer that slides that Anna showed you about the different processes was for our regional user groups, so the regional histopathology laboratories. Of course, we need to thank to Mainland as well, and all the cut-up and personnel, actually every single person, including consultants over there in histopathology for the CUH cases. So, hello, I'm sure most of you will know me, bothering you with questions and asking you things to do. I'm Livia, I'm one of the hematopathologists down here in Hodds. And just as a little bit of background, how I ended up being here and why I'm not a level 5 or over in the ATC is I am a trained histopathologist, but I like to say that I've been pipetting since I was 16. I have really great experience in molecular diagnostics and cancer research. So I'm a little bit of a hybrid between a molecular person and a histopathology morphology person, which is not that logical, to be honest with you. Therefore, that's how I ended up doing hematopathology, because you need both of those things to put together to arrive at a diagnosis. So in addition to what Anna mentioned about, and I'm going to talk a bit more about lymphoma in this, quite a lot of our cases are life-threatening, and as she said, we're getting less and less tissue and we need to do more and more on it, and it is invaluable that the tissue is preserved and optimized as much as possible. And I can't thank all the teams in Histo and the GLH enough to work with us in making sure that every single tiny bit of tissue is used and not wasted. And also another important thing, particularly for lymphomas as well, there's no follow-up excision, there's no follow-up anything. The diagnosis we establish at diagnosis in the first sample determines primary, often secondary, and sometimes even third line treatment as well. So it is essential to get it right up front. And again, just dovetailing into tissue preservation, why it is so important, because sometimes our clinicians can't even wait for immuno to come out. They want to tell us whether the sample they managed to get from a patient is sufficient enough to establish a diagnosis or not. And from regional hospitals, what we often have is just an H&E. So we don't know how much is in the block. We don't know how many sections they've cut. And it can be incredibly misleading to tell them, yes, I can make a diagnosis, just to find that block has already been cut out. So again, all of that put together, working closely with Mainland, working closely with immuno, how we are able to tell them immediately they can treat the patient or not. And again, there's lots of tests available in GLH at the moment, but rather unique thing about lymphoma in particular, in addition to the myeloid neoplasia as well, that quite the bulk of the molecular tests need to happen before treatment starts. And therefore we have really high level of demands to meet the needs of the 2-week wait cancer pathway and the patient in general. At the moment, for lymphoma, we do very little in terms of prognostication, although watch this space this is to further expand in the coming months and years. So yes, we have to fit in an awful lot into that pre-treatment period. So, and I'm going to talk you through how we kind of arrive at the notion of wanting to be a hematopathologist from the point of view and the questions that I was getting when I went into hematopatology. One of the first things people told me, you don't need to be a monospecialist to be a hematopathologist. I know what Hodgkin lymphoma looks like, I can diagnose it. And I completely agree with that statement. But as Anna said, we have an awful lot of new entities and they're forever coming. And I like to joke about the fact that our clinicians are often one or rather two WHO book editions behind us when it comes to being aware of entities. And this is very well represented, but the case of this young man who presented to actually our hospital with these massive masses in the front of his neck going down towards his chest. These are the bright spots you can see on the imaging. And other than that, he had nothing else, just these big masses in his neck. And I spotted a few names of histopathologists and trainees on the call. We can argue all we want how to describe these cells. I think morphology is fairly subjective when it comes to describing cells, but I think we can all agree that this is a nasty looking thing. Pleomorphic cells are there, which means that the cells look different to each other and there's high variability, size, shape, and overall just morphological features. And for those who don't work in the histopathology diagnostic setting, whenever a sample like this comes in and we don't know what we're dealing with, you need to figure out which team needs to deal with it. Is it a carcinoma? Is it a lymphoma? Is it something else? Is it something completely unusual? So all people working in histopathology departments in the region need to decide that. The pathologists do that most often. And for the pathologists in there, there are a few different ways you can deal with this, and I'm not going to tell you what to do. But what I would like to ask you, just in your head, just quickly think what antibodies you would use to kind of figure out whether or not this is a hematological malignancy. And if you're one of the people who would do 45 just to direct cases to Hodds, then you would have been absolutely right. And this would have come to Hodds because this is in fact a lymphoneoplasm, a very nasty one, as you can see by the brown spots on the MIP stain. And those who would do a 3 and a 20 as opposed to 45, the 3 and a 5 wouldn't have helped you, and neither would have the CD20, because this is something, a neoplasm that's negative for both CD3 and CD20, as well as all other B-cell raised antigens that we threw at it. But what you shouldn't really forget is that plasma cells and things post-germinal stent are also B cells, and those passing the the plasma bus differentiation tend to lose their pan-B-cell antigen expression, and they tend to be positive for RF4, 11, and CD138. And this was indeed a neoplasm that has reached that level of differentiation. And throwing 20 more immunostains on it, we figured out that this malignant population of cells was actually staining with ALK. And as you can see here, this is all the workup that was done on this case to arrive at this diagnosis. And it was all needed. And it was performed a stepwise process to exclude chunks of different diagnostics along the way. And in fact, this case needed further sections to be cut for some additional immunohistochemistry. And thankfully, with the help of the immunoteam, this was cut at the time. The fish sections were cut at the time as the immunohistochemistry. So we have preserved an awful lot of tissue that we can use going forward should we need to, because this is an extremely rare case of ALK-positive large B-cell lymphoma. And there are only a handful of case reports out there in the literature. It is a provisional entity and it's going to be full entity now. There's not many cases out there. And in small laboratories, in DGHs, you might not have the range of antibodies that would be required to establish this diagnosis. And it is important to give prognostic information to the patient, as well as the presence of ALK translocation would allow this person to apply for ALK inhibitor treatment or compassionate access, which is something that the clinicians are actually pursuing at the moment. So rare things are rare, and you need to have seen a lot to think about them, and you need to have the tools to be able to work with them. Okay, but you report lymph nodes, that makes sense. Do you need to report bone marrows, or should we have the hematologist report all the bone marrows? There are two schools of thought out there. I think a good sort of equivalent example would be, would you want breast carcinoma staged, graded, and treated on the basis of aspirate morphology or cytological specimens? I'm going to leave that hanging there, but probably not. And this is well demonstrated by the case of this patient who was 69-year-old and presented to us with quite prominent thrombocytopenia, and he was anemic as well, as I'm just going to help here and tell you that he also had monocytosis. And on imaging, he just had rather vague soft tissue type changes, which they couldn't really pinpoint an etiology for. But there was increased uptake in the bone marrow, and therefore they took a bone marrow sample to see what is going on. So as Anna said, aspirate morphology and flow cytometry is usually out within the day. And indeed, they were able to make a diagnosis of chronic myelomonocytic leukemia with 15% blasts on the aspirate morphology, the result of which is corroborated by the findings of flow cytometry. And then when you look at the bone marrow that came after a decalcification and sectioning and staining, you can see that there are two different areas in this sample. For those who don't look at many slides, they're the more blue and more the pale pink areas. And you don't need to be a pathologist to tell that they look a little bit different, even if it's just their colors. And when you look at the pale pink areas, you can see that there are these cells that are rather large. For comparison, this is an erythroid cell and there's some lymphoid cells in the background. These are humongous. They are what we call xanthomatous cytoplasm, and some of the cells are rather big, others are a little bit smaller. And these are histiocytic cells, rather variable in morphology. Some of them show emperipoiesis when they kind of engulf and grow around other cells. So this is a population we definitely need to further classify by immunohistochemistry. And this is actually not something that was described in the aspirate slide, although there was mention of hemophagocytosis. Whether or not this could have been some of these smaller cells with emperipoiesis is up for debate. But when looking at these cells, you can see that they express a profile that is consistent with a histiocytic population with expression factor 13A S100 and BRAF V600A mutation-specific antibody also highlighted these cells, which is indicative of underlying BRAF V600E mutation. So this immunoprofile is entirely diagnostic, and we're going to discuss of what it is diagnostic of. But when you look at the more blue areas, you can see there's an awful lot of cells for a 70-year-old. This should be reversed. You should have the amount of cells that you see in fat spaces, and fat spaces should take up about 70% of the area. So this should be reversed. And I'm not going to bore you with the details, but what you can find here, there are these plastic changes. There's this erythropoiesis. These are the erythroid islands, as these megakaryocytes don't look normal at all. They are dysplastic as well. But what we couldn't see an excess of cells with an immune phenotype that would allow us to consider them as blast on immunohistochemistry. And this is incredibly important in this specific neoplasm because blasts are defined as myeloid blasts as well as promonocytes, and promonocytes are not something we can identify currently by flow cytometry or histomorphology. So establishing a diagnosis of chronic or acute myelomonocytic leukemia is entirely based on morphology. I do like a bit of morphology here. And again, we just use some more immunostains to help us bring out these different cell lineages in the marrow to absolutely classify them and assess them very, very well. And of course, we went on and now we do a lot of NGS testing on these cases for the reasons Anna detailed, and this was the result. So there's been an awful lot of slides here, an awful lot of modalities and awful lot of information thrown at you, but how do you put all of this together? Let me talk you through it. So here's your patient. He's anemic, he's thrombocytopenic, and he's got lots of monocytes in his blood. Within a few hours, we receive an aspirate, and Anna has established a diagnosis of CMML2 and mentions a little bit of hemophagocytosis. Great, we can explain why the patient's having those issues in their peripheral blood. We have a diagnosis, and it's very nicely proven and supported by flow cytometry results. But we do have this case of hemophagocytosis. And on radiology, there was these odd changes that could not have been described or explained by the myeloid neoplasm that is on there. And that's where the histology comes in to complete a full circle of diagnostics. Yes, we did find a myeloid monocytic leukemia, but we already had a blast count. We didn't need to worry about CD30 positive cells. And we could actually explain with what we found in the bone marrow, the imaging changes and potentially the hemophagocytosis as well, and diagnosed Erdheim-Chester disease, which is a type of clonal histiocytic disorder. And the NGS results, if you break it down, and you know how to break it down into two groups, will absolutely support all of this, because the gene alterations in the red box are not at all unusual in cases of CMML, whereas the BRAF mutation is something we often see in Erdheim-Chester disease. And actually, it's up for question whether or not there might even be TET2 mutation in the Erdheim-Chester component, but that's not something we can tell without further microdissection, etc. So yes, this is how we arrived at the diagnosis that we arrived at. And again, these things are rare, and there's not an awful lot of information on how these develop. But one of the scenarios, which is likely what's happening in our case as well, is there's an event that happened in a common precursor, and there was divergent differentiation towards a myeloid neoplasm and a clonal histiocytic disorder, which would be supported by the molecular findings as well. So there's an awful lot we can do, but all of this needs to be looked at and brought together into one unifying diagnosis. And that will help us with staging as well, and these disease assessment, because two components can appear and disappear as time goes with treatment. So again, if this talk is recorded, so if you want to go back and take screen grabs for whatever purpose of these things, I just put some information out there. Okay, so you need to know about NGS, and you need to work with your colleagues and have coffee with them and be nice, but do you need to know about cytogenetics as well? I mean, I'm not a cytogeneticist, but rubbish in, rubbish out. You only get an answer to the question you ask. And this is well illustrated by this case of a 70-year-old man who just presented with some achy arms and shortness of breath and night sweats, which is a very heme type presentation. And he was a little bit anemic, bit thrombocytopenic, bit increased white cell count as well, but not an awful lot to go off of. And the interesting thing was that actually in this case, aspirate and flow cytometry were not particularly helpful because they were essentially a dry tap, but put together with the peripheral blood film, there was a leukoerythroblastic picture and a little bit of eosinophilia. Leukoerythroblastic just means that cells are being a little bit squished in them or potentially and kind of pushed out to the periphery like that. And we can very nicely explain that with trophine morphology. What you can see here on the reticle in these black and sort of golden lines is increased reticulin fibers. I can see the cells lining up as well because the fibrosis, the reticulin fibers pushing them together. Another thing you can see very well here is these cells, which is an increased numbers of eosinophils. We saw those in the aspirate as well. So we have lots of cells with lots of fibrosis and lots of eosinophils as well. I'm not going to bore you with this, but there was expansion of the myeloid cells with eosinophils. There was dysplasia as well in the erythroid and megakaryocyte lineages as well. So for intended purposes, just on the trophine morphology, this did look like a myeloid neoplasm. But then there was a second component there as well. There was an odd infiltrative B cells as shown here by CD20. And their immunophenotype was not that of an immature B cell. It wasn't a hematochrome, but also wasn't specific of a lymphoma. But there was an awful lot of these B cells there we didn't know what to do with. And one thing you could do, and we're going to come back around to this again, is do clonality analysis. See if these B cells are clonal or not. Do we need to worry about lymphoma or leukemia? So we did do clonality analysis and we got a report of weak clonal in polyclonal background back. And that was the report. I kind of amended here and kind of tweaked it a little bit, and I'll tell you a bit later why. But you can see that normal population of B cells will show this nice Gaussian distribution because they have different lengths of rearranged segments, whereas if you have one population that's originating from one clone, you will have one rearrangement stand out. But I would also mention here that actually you don't have the Gaussian distribution in the background, which to my eyes, it means that there were not an awful lot of B cells in this sample. Therefore, I cannot really exclude that there was preferential amplification, whether there was a clone, the segment of which just really, really loved and grabbed all the primers and just shot out of proportion. So that's a possibility. But when I see eosinophilia and myeloneoplasia and odd lymphoid infiltrates, I immediately go to the chapter of the WHO book that deals with myeloid lymphoneoplasia with eosinophilia and associated translocations. That's a mouthful. We usually just call them flippy floppies because there's a number of translocations that tend to be associated with this neoplasia, which we can test for. So we did ask Bridget and her team over and the GLH to do the FISH. And what they could find is there was JAK break apart, as well as BCL break apart. But there was no fusion because we don't really target fusion between the two at FISH level. But we could stipulate that probably is what's happening. There is a translocation between JAK2 and BCR. And this is just an awful lot for information for all of those who would want to go back and read up a bit more about it. But essentially, we could establish the diagnosis of a aforementioned myeloid lymphoneoplasm with eosinophilia with this odd translocation, which is a rare variant of a provisional entity. So it's the rarest form of anything. But why is it important? Because these translocations are actually targetable. So in patients where there would be otherwise a poor outcome and or a transplant, targeting this translocation could be incredibly helpful and could just give them a better prognosis. And this is actually what happened with this person. He was treated with ruxolitinib, which is a JAK2 inhibitor, and some EPO to push up the red cell count. And he was doing well for a year, but then he became symptomatic again and came back to the clinic. And they didn't need a trophon biopsy at that point to make a diagnosis of what's going on. The marrow was fully involved by B lymphoblastic leukemia. But you can see here on the histology sign as well, these are immature TDT positive, PAX5 positive B cells. And now, slightly academic, but nevertheless interesting question. Is this a B cell population that came from that tiny peak, that tiny clonal population that we could see at presentation? Should we have done anything at that point? So we did do clonality analysis, and it was clonal, and it's clearly clonal. There was no polyclonality, but it was a different a different rearrangement that it was there. So it's not from that clone that was there at presentation. It just came about later on. And when there's a dual pathology, we often see that if you treat one of the components, the other one will grow out of proportion and vice versa. So you never know what you're going to find in the sample that's coming back. Just to prove that this was the same thing, we did test for the translocation, which actually was there in the cells, B cells, as well as it was there in the previous sample. So they changed the ALL treatment, and he did really well for a while, but unfortunately he did pass away. Okay. So you need to know what to request, you need to read the book, but the book is there, you can look it up. You don't need to know all of these things. You can just go back to the book and refer back to it. Surely you don't need to report any of this molecular tests because the scientists will know what they're reporting. They know what they're going to deal with. Well, let's talk about that. This is the patient, and this is all I know about this patient. He, for some reason, had some kind of an FNA of the right axillary node. We don't know why, but there was in diagnostic, so they decided to go back and take a bigger chunk out, a core biopsy. And those who are familiar looking at axillary lymph node core biopsies, this is not a particularly sporting one. You have the capsule of the lymph node at either end, and they literally just skimming the top of the lymph node with the biopsy. You can see that because the capsule is dipping in here in the middle. So it's a very subcortical, very superficial sample that we're looking at. But actually, where you're looking at it, there's not an awful lot to be seen. There are little bits of primary follicles, there are sinuses that are open, and doesn't look particularly exciting. But because we are a tertiary referral center, and if our colleagues from any of the pathology departments are concerned about lymphoid malignancy, whatever the reason, we don't ask questions, but we do some immunohistochemistry to get down to that deeper level and understand what's going on. So the CD3 positive T cells are where they should be. So the TD20 positive B cells are where they should be predominantly in these little nodules. But you can see in between there's some positive cells as well. We see some of these cells in subcapsular superficial samples, but this is a little bit more than I would expect. On a good day, I probably wouldn't have done anything with it. On a bad day, which I probably had at the time of requesting clonality, I was actually concerned about them. So one of the reasons I couldn't just let go of this case, but you can see CD23 positive cells kind of creeping out there in the middle, and there's a bit of positivity in this zone as well. We can see some in normalish follicles. We can see some going out as well, so it wouldn't necessarily make me worried. But when I looked closer in the CD5, I could see there were more 5 positive cells than 3 positive cells. So these are unlikely to be T cells. They are likely to be B cells that had aberrant CD5 expression. And that was the same as CD43 as well. It's expressed by T cells, but looks like it's also expressed by our B cells as well, which again, it should not be. Again, CD5 and CD43 are difficult to assess when there's lots of T cells in the background, but I was worried enough in this case to go ahead and do clonality results. And lo and behold, the report I got back, and I didn't report this case, I do report clonality, but this one I didn't report. The report I got back was clonal in polyclonal background, essentially the same report as it was there in the previous case. Can we disregard this? Well, the answer is here. Sometimes I do go back and I do look at some plots just to decide about whether or not this clone is significant. As you can see, there's very little in the way of polyclonal background. Most of the B cells that are there are from a single cell, they're clonal. So when you go back and look at your histology again, which we do once the clonality results come back, you can see that in fact, this population, this 5 and 23 positive population, with 43 positivity, is your clonal population. And just by looking in this pattern, you can tell that actually most cells, most B cells in the sample are clonal. And therefore, this is not only a clonal population of B cells, it's a neoplastic clonal B cell process. So depending on whether this is just sort of blood in sinuses and cells being carried by the blood getting to the lymph node. This could be either monoclonal B lymphocytosis or CLL, SLL that's emerging or undersampled. So they tell them to go back and said, we were worried about this patient. So they did some imaging and I find an awful lot of lymph nodes, tiny lymph nodes in him, mainly in his cavities, which no one could have palpated. So actually, in fact, he did have CLL. So there was this interplay between really good quality immunohistochemistry and molecular results, which then were actually reassessed in light of histology and a kind of feedback to the primary reporting. A second reporting person happened as well, saying it could be extremely useful to quantify what you mean by clonal. Is it clonal in a poly background or clonal in a poly background or not at all, either of them? Because you can't make an integrated report at the molecular reporting level, but when you're integrating results, you need the molecular results to be as helpful as possibly can. So this is my little story. Thank you for listening.
Thank you all. Fantastic talks. Livia, I think there'll be a lot of questions for you once people have ingested what you've said, because I found that fascinating, but I don't understand it all. So I'll have to think about lots of things. Can I just ask you both before I start, what the WHO classification, how do new things like you just described get on there? Do you report them back, or are they from peer-reviewed cases? How does all that get into that WHO handbook, is what I'm saying?
I once went to a talk about this and I can't remember the details, but basically the criteria for something to get into the WHO are very, very stringent. So it has to be, I don't know whether anyone else can give a more refined answer than this, but essentially it has to be identified as a discrete entity in multiple publications, and there has to be something that delineates it. So for example, it might have a discrete, within AML, for example, entities are marked out because they have, for example, a discrete prognosis. So AML with mutated NPM1 has quite a specific prognosis, and that has to be identified in multiple publications. And some things go in as provisional entities. So we used to have something called AML with mutated RUNX1. That was in the last WHO, and that's actually been removed in the current WHO because it's now been worked out that that's actually a mishmash of different entities. So essentially, does anyone else have anything else to add to that?
So it's a politically loaded question that usually is the WHO who's driving the process, the IRC, and there's some clinical advisory committees who work together. So people on the clinical advisory committee are well-established and respected experts in their field, and they work with the editorial board of the IRC. So that's kind of the background of it. But sometimes things make it into WHO book that can discard it after a while. If you think back, the divergent classification is only 20 years ago, before WHO books came out. We were just calling things large cell lymphomas. There was no breakdown. So almost as if something makes it into the WHO book and you start calling things, then people start looking into it and research it and go back at data from various trials to see if it really is a thing that's proof of the pudding. And similarly, on the lymphoma side of things, we had triple hit lymphomas in the previous WHO classification, but we don't have triple hit lymphomas in the upcoming WHO classification. BSL6 translocation has been removed because they don't think it contributes to the prognosis or treatment outcome of the patients, largely due to the fact that actually can have different molecular alteration. So yeah.
Thank you. And does that WHO, excuse my ignorance, does that inform prognosis as well? Is that why it gets in, because there's a prognostic indicator and a therapeutic indicator? Or is
yes,
it just
so a lot of the entities have a specific prognostic. They don't all have a specific prognostic value, but a lot of them will do. They may be defined as entities because they have very discrete morphological findings, or because they have such a specific genetic signature that it's very obviously a pathological entity by itself. But where there is, if something has a very specific prognostic the WHO gives you all that information within the book. So and we rely on it to put that information into our integrated reports as well.
I think it's important to say that the WHO sort of gives a single classification system. So in histopathology, classically, there have been a whole array of different classification schemes. So the WHO brings all that together. So across the world, we are talking about the same entity. So then you define something as the same entity. And of course, then you can use comparative data on outcomes, treatment, etc., etc. So before it was all a little bit confused, and the various groups developed their own systems. So it became slightly sort of political.
And the idea is that when you put a patient into a clinical trial with entity X, that the results of that clinical trial can then be extrapolated to any patient with that entity.
Yeah, I understand that.
Unfortunately, with the WHO this year, a competing group of individuals has come up with a completely different classification. So we've now got to choose which one to,
right. I just need to be able to answer my colleagues when they wonder why they're doing so much immunohistochemistry. That's all. So
oh, right, yeah.
It's
that's
okay,
why.
Don't worry.
Yes, and also that kind of just comes a full circle, because you need to be able to actually call those entities. There is pragmatism in issuing lymphoma or any other diagnosis can be useful at a given time for a given patient, but going forward, it's not particularly useful for getting to know more about things. So that's why you kind of have to see a lot.
Well, we're at time. I'd just like to, is there any other questions from anybody? Do you want to put in the chat room or shout? Thank you both all very much. That was really, really fascinating. Lots of people won't understand what SIH-MDS was until they've had this talk, and I believe they do now, and the importance of the histopathology in the diagnosis of hematological malignancies. So it is all going to be available on the Futures website. So please go back, and I'm sure Anna and Livia in particular will be able to answer any questions if you've looked at something and thought, oh, I don't quite get that.
Just drop us an email, absolutely.
Yeah, and as I say, I'll talk to Dave, and we're going to do a bit on flow cytometry later in the year for one of our talks. Thank you all very much.
Thanks for having us.
Great talk.
Okay,
Take care.
Fantastic.
Bye.
Thank you.